Good evening, everybody. Today's topic for today's presentation is effect of nasal CPAP versus heated humidified high flow nasal cannula on feeding intolerance in preterm infants with respiratory distress syndrome. So, this study is the Entares randomized control trial, that is enteral nutrition tolerance and non-invasive respiratory support in preterm infants. It was conducted in 13 neonatal intensive care units in Italy, published in JAMA Network Open Journal, which has an impact factor of 13.8, and it was published on July 12, 2023. So, PICO statement, the population was consisting of all infants with gestational age between 25 and 29 weeks, 7 days of life or less, suitability for enteral feeding, that is less than 75 ml per kg per day if already started, and RDS. The intervention and comparison was randomization of infants to either the nasal CPAP or triple HFNC arm. The outcome, primary outcome was the time to full enteral feeding defined as an enteral intake of 150 ml per kg per day. Time interval was between January 2019 and October 2021. So this is the consort checklist that was followed as per the guidelines, and we will be discussing each point in further slides. So introduction. Respiratory distress syndrome is a common condition in preterm infants, and the use of non-invasive respiratory support reduces the need for mechanical ventilation, risk of death, intraventricular hemorrhage, and bronchopulmonary dysplasia in these infants. So non-invasive respiratory support could affect feeding tolerance through several mechanisms, and the mechanisms involved include pressurized gas flows through the non-invasive respiratory support system are transmitted to the gastrointestinal tract and causing a gaseous distension. This gaseous distension further causes mucosal inflammation, causing cytokine release. And the oxygen-enriched air mixture causes an imbalance in intestinal microbial flora. Pressure by the non-invasive respiratory system also affects the gastric emptying and may cause GER and affect the mesenteric flow. So basically, most common modalities of a non-invasive respiratory support system are nasal CPAP and triple HFNC. So a recent meta-analysis suggested the benefits of triple HFNC versus nasal CPAP for feeding tolerance. So the null hypothesis was that triple HFNC may not affect feeding intolerance to a lesser extent than nasal CPAP. Whereas the alternate hypothesis was, as per this protocol, that triple HFNC may affect feeding intolerance to a lesser extent compared to CPAP. So as per the consort checklist, this trial was not identified as randomized trial in the title, and there was a structured summary of the trial design, methods, results, and conclusions. There was a scientific background explanation of rationale given, and scientific objectives or hypothesis was described well. So what are the aims and objectives? It was to evaluate the effect of nasal CPAP versus triple HFNC on high-risk preterm infants with respiratory distress syndrome on the primary outcome of time to full enteral feeding, which is defined as an enteral intake of 150 ml per kg per day. The study design, it was a randomized controlled interventional open label multicentric trial, and followed consort checklist. So description of study design was given well. The inclusion criteria, it involved all neonates between 25 to 29 weeks of gestational age with diagnosis of RDS, with after stability on triple HFNC or nasal CPAP since at least 48 hours. So stability test was conducted for 48 hours, after which the babies were enrolled. So this stability test involved the following parameters, that is saturation of between 90 to 95%, PCO2 of less than 60 mm of mercury, FiO2 of less than 40%, Silverman score of less than equal to 6, less than equal to 2 apnea episodes per hour with CPAP less than equal to 7 centimeters of water if the baby is on nasal CPAP, and flow of less than equal to 6 liters per minute if the baby is on triple HFNC. Again, less than equal to 7 days of life. Suitability to start enteral feeding less than 75 ml per kg per day already started, and parental written consent. Exclusion criteria involved neurological or surgical diseases, babies with sepsis, babies with chromosomal abnormalities or major malformations. So again, eligibility criteria and settings and location data were well described as per the consort checklist. The primary outcome was time to reach full enteral feeding, defined as an enteral intake of 150 ml per kg per day in the number of days. The secondary outcomes were, they had 14 secondary outcomes. So it was half enteral feeding time, that is time to reach up to 75 ml per kg per day in the number of days. Enteral feeding interruptions, not given feeds, pathologic gastric residuals, vomits and or regurgitations, abdominal distension, beginning of oral feeding, full oral feeding time, weight growth, duration of respiratory support assigned at randomization, total duration of respiratory support needed, failure of the respiratory support assigned at randomization, length of hospital stay, and occurrence of complications as NEC, bowel perforation, pneumothorax, BPD, or ROP. So again, pre-specified primary and secondary outcomes were very well defined as per the checklist. So what is the criteria for the interruption of enteral feeding? They had minor and major criteria. So in minor criteria, it involved abdominal distension, visible bowel loops, abdominal distension responsive to gastric distension or rectal stimulation, then regurgitation or vomits less than equal to 2 episodes between 2 feeds or in the previous 3 hours if not fed, gastric residual volumes less than 100% of previous feed with mucus stools, cardiorespiratory events more than equal to 3 events per hour. The major criteria involved dyschromic abdominal wall, painful abdominal distension not responsive to rectal stimulation, more than 2 episodes of regurgitation or vomits between 2 feeds or in the previous 3 hours if not fed, bilious vomiting or hematemesis, gastric residual volume more than equal to 100% of previous feed or hematic or fecaloid gastric residual volume, hematic stools, cardiorespiratory events more than equal to 1 extreme CR event. So between 0 to 1 minor criteria, it was decided to continue enteral feedings with increments as per protocol, that is maximum of 30 ml per kg per day. With 2 minor criteria, stop increasing feeds, reassess prior to the next feed, and evaluate gastric residual volume if not done before. If 2 minor criteria in at least 2 consecutive evaluations, it was considered to reduce volume of feed. With 1 major criteria or 3 minor criteria, interrupt enteral feeding and reassess prior to the next feed. So this was the criteria for interruption followed while feeding the babies. A sample size of 123 infants per group was estimated, and to detect a difference of 30% on the primary outcome of time to reach full enteral feeding, which was projected to be 19.6 days based on data from the participating NICUs the year before the trial started, with a 90% power and using the two-sided log rank test with a significance level of p is equal to 0.05, assuming a dropout of 13%, a total of 282 eligible infants were required. Again, sample size determination was described well as per the consort checklist. Methods followed. So infants were randomized to one of the 2 NRS groups by block randomization. And software was designed to automatically generate a randomization code and to establish in each research unit a balance between patients with less than 28 weeks gestation and patients with at least 28 weeks gestation in both the groups. So basically, they had a population of 25 to 29 weeks, and they assured that each group, nasal CPAP as well as HFNC, has both between 25. They stratified the groups into 25 to 28 weeks and 28 to 29 weeks into each nasal CPAP and HFNC group. So again, as per the consort checklist, methods used to generate the random allocation sequence were well described with the type of randomization described. Nutritional data were recorded daily until the full enteral feeding was reached. Respiratory data were recorded at each change of respiratory support until its discontinuation. The occurrence of comorbidity was recorded until discharge, and data were collected anonymously by a web-based database. So, the statistical analysis used was the intention to treat protocol. So, to differentiate between intention to treat and per protocol analysis is usually used in is the choice of analysis in non-inferiority trials. So what happens is in intention to treat analysis, every patient that is randomized to the clinical study should enter the primary analysis in the same arm. Whereas in per protocol, not all randomized population would enter the analysis population. Again, in intention to treat, number of patients randomized is equal to the number of patients analyzed. And in per protocol, number of patients randomized is more than the number of patients analyzed. Again, in intention to treat, even if the patient receives incomplete treatment or receives other treatment, still the patient will remain in that group to which that patient is randomized. Whereas in per protocol, only those patients who strictly adhere to the protocol are analyzed. Then in intention to treat, it avoids potential bias due to exclusion of patients. And in per protocol, treatment effect which would occur under optimal conditions. That is, what is the effect if the patients are fully compliant? That is the advantage of per protocol analysis. So intention to treat tends to underestimate an effect conservative approach in a clinical trial, and it is a method of choice for primary analysis. Moving on to the statistical analysis, the time to reach full enteral feeding was computed as the number of days from randomization to full enteral feed achievement, and it was estimated using the Kaplan-Meier method and the log rank test. So Kaplan-Meier survival method is used for basically is a non-parametric estimator of survival, and this was used to compute the number of days until which the full enteral feeds were reached. And then they used what is called as a log rank test. So log rank test is basically used to assess whether two Kaplan-Meier curves from two subpopulations are statistically different. Here we had two subpopulations, that is one of the nasal CPAP group and one of the triple HFNC group. So this log rank test was used to compare the two curves of CPAP as well as HFNC group. So what does the log rank test actually signify here? It is used in survival time analysis, and it compares the distribution of time until an event occurs of two or more samples. So log rank test is going to give us a p-value, and if this p-value is more than 0.05, then the null hypothesis is retained. Whereas if it is less than 0.05, the null hypothesis is rejected. The statistical analysis of the secondary outcomes was described as per the following table, that the nutritional outcomes were analyzed using the regression analysis of Poisson regression. The growth outcomes were analyzed using linear regression, and the respiratory outcomes were used using Kruskal-Wallis test, Fisher exact test. Also, they use what is called as a Bonferroni correction. And Bonferroni correction is basically used in those analysis where we have multiple comparisons between multiple subgroups. So here we had 4 subgroups to analyze, and which had infinite multiple possibilities with 14 secondary outcomes. So in Bonferroni correction, they use what is called as a corrected p-value. Usually what is standardly taken as p-value is 0.05. Whereas in Bonferroni correction, a corrected p-value is calculated using alpha divided by a constant. Alpha is 0.05 and constant is calculated as per the number of outcomes and comparisons. So here the corrected p-value, the significance level was set at p of 0.003. So what is p-value? It is basically the probability of the null hypothesis being true by chance alone. So a p-value of 0.05 or less is commonly used to assign significance. Here, normally we use this 0.05 as the standard, but here after giving the correction of the Bonferroni correction was given, and the p-value was set at 0.003. So this basically helps us in reducing type 1 errors. So this value basically informs the investigator that there is at least 95% chance that the two samples represent different populations. And SAS version was used to SAS version 9.4 was used to process data and fit statistical models. Again, statistical methods used to compare groups for primary and secondary outcomes were well described as per the concert checklist, and methods used for subgroup analysis were well described. Moving on to the results. So there were 13 participating NICUs. Trial enrollment done from January 2019 to October 2021. And 475 eligible infants, out of which 247 were randomized. Nasal CPAP group had 122. Triple HFNC group had 125 babies. So there were 475 eligible infants, out of which 168 were excluded due to the reasons as given. There were 307 who underwent stability test, out of which 60 were excluded, and ultimately 247 were randomized. So out of 247, 122 went into the nasal CPAP group, 125 went into the triple HFNC group. Now, out of 122 nasal CPAP group, 9 were censored infants. So 9 censored infants involved, 4 discharged with an enteral intake of less than 150 ml per kg per day. 1 was transferred, 2 died, and 1 had congenital malformation and sepsis each. So ultimately, 113 were included in the primary outcome analysis. Out of the 125 triple HFNC group, 10 were censored infants, out of which 5 were discharged with an enteral intake of less than 150 ml per kg per day. 2 died, 2 withdrew consent, and 1 had sepsis. So 115 were included in the primary outcome analysis. These are the baseline characteristics. So male and female, most of the characteristics were comparable. Male and female sex in both the groups were comparable. Birth weight was also comparable with 1054 in nasal CPAP and 1085 in triple HFNC group. Both the groups consisted of IGR babies in equal numbers, that is 20 in CPAP and 8 in triple HFNC. Age at recruitment in both the groups were comparable, 4 days in nasal CPAP and 5 days in triple HFNC group. The FiO2 at requirement was 21% in both nasal CPAP and triple HFNC group. The primary outcome measures, they use as stated earlier, they use the Kaplan-Meier survival curve, time to event analysis. So time to reach full enteral feeding was 14 days in both nasal CPAP and triple HFNC group. Nasal CPAP group had a 95% confidence interval of 11 to 15 days, whereas triple HFNC group had confidence interval of 12 to 18 days. Secondary outcomes, there was no statistically significant difference related to secondary outcomes in both the groups, and the mean length of hospital stay was similar in both the groups. So again, the consort checklist was followed, the participant flow, the dates defining periods of recruitment, why trial was ended, baseline data and numbers were analyzed, outcomes and estimation was well defined, and adverse effects were noted well. Moving on to the discussion. So no differences in time to reach full enteral feeding were found between the nasal CPAP and triple HFNC groups, thus accepting the null hypothesis. Hypothesis that triple HFNC affects feeding intolerance to a lesser extent was based on the fact that triple HFNC rather than nasal CPAP treatment experienced less feeding intolerance, that is secondary to less gastric distension from high positive pressure. Again, discomfort from nasal prongs and nasopharyngeal tube may be affecting stress and fatigue from overhandling, and hesitation in increasing volume of enteral feeding. However, this can be contradicted by the fact that high flow of oxygen or air delivered by triple HFNC devices, this increases the pharyngeal pressure by 0.8 centimeters of water for each 1 liter per minute. And therefore, triple HFNC can have the same complications as nasal CPAP on gastric and abdominal distension. So in a study conducted by Amendolia et al., who studied 104 very low birth weight infants, did not find differences in time to reach full enteral feedings between infants who were treated with nasal CPAP versus those who used triple HFNC. Recent meta-analysis supports the hypothesis reporting that earlier full enteral feeding was reached with triple HFNC compared with CPAP as the primary respiratory support. So with respect to respiratory outcomes, nasal CPAP and triple HFNC had similar rates of failure and change in NRS. That is, change from nasal CPAP to triple HFNC was mostly due to poor compliance with the interface, and triple HFNC was used as a weaning technique from nasal CPAP. Again, the switch from triple HFNC to nasal CPAP was mainly due to lower respiratory efficacy of triple HFNC. So the major limitation of this study was that there was an inability to mask clinicians during randomization, and this study focused on a population of stable infants. Thus, the efficacy of the two techniques cannot be generalized to their use as a first intention treatment. Again, checklist or consort checklist was followed, like limitations, generalizability, interpretation, registration number and trial registry, and availability all were well defined in the study. Concluding my study, the results of this trial showed that there was no difference in feeding intolerance between infants in the nasal CPAP and triple HFNC groups, although some short-term respiratory outcomes were better with nasal CPAP. Thus, respiratory care should be tailored by choosing appropriate NRS technique based on the respiratory efficacy and patient compliance rather than its effect on feeding intolerance. So, moving on to the CAS checklist. Did the study address a clearly focused research question? So, yes. Was the assignment of participants to interventions randomized? Yes. Were all participants who entered the study accounted for at its conclusion? Yes, since it was an intention to treat analysis. Were the participants blind to intervention they were given? Yes. Were the investigators blind to the intervention they were giving to the participants? So, no, it was a non-blinded study. And were the people assessing or analyzing the outcome blinded? So, yes. Were the study groups similar at the start of the randomized control trial? Yes, all the baseline characteristics were similar. Apart from the experimental intervention, did each study group receive the same level of care? So yes, that is, they were treated equally. Were the effects of intervention reported comprehensively? Yes, they were reported. Was the precision of the estimate of the intervention or treatment effect reported? Yes, confidence intervals were reported. Do the benefits of the experimental intervention outweigh the harms and costs? So we can't tell because a cost-effective analysis or anything related to the funding was not very well described in the study. Can the results be applied to your local population or in your context? Yes. And would the experimental intervention provide greater value to the people in your care than any of the existing interventions? So yes. Thank you.
Very nice presentation, Nikita. If anybody has any queries, you can type in the chat box. Just Nikita, I want to ask one question. Why did they do stability test in their study population? Can you tell?
So the stability test was done to in order to like they first tested if the babies were stable enough to continue on nasal CPAP or HFNC so that it could be continued and any protocol deviation could be avoided.
Yes, that is one of the reasons. And the other reason is that we do not have any definite evidence or in this age group, like 25 to 29 weekers, that HFNC could be used as means at least in post-extubation or a primary modality. May not be primary modality or maybe post-extubation. So in this age group, so before doing that, they wanted to check for the stability test because also in their protocol, what they mentioned is that they have a lot of babies, they were crossover from one group to the other. Like few who failed HFNC were given CPAP trial, and that is the reason they did this adjusted analysis, because most of the results in the secondary outcomes are mentioned in the risk ratio, and they were usually done through regression analysis.
Yes.
So if you can see the events, respiratory events, that secondary outcome criteria, no? The number of respiratory events, those counts were done by that Poisson analysis, regression, and the other one were done by general linear model. So they use regression analysis to adjust these variables because there are a lot of crossovers, and to find out the association among them, they did this regression. And the other thing you said about the new thing, then what they did was a Bonferroni correction.
Yes, sir.
So basically, to make things a little bit clear, the Bonferroni correction is usually done if there are multiple comparisons, as you said. That's correct. And also when you have a multiple t-tests, because we have lot of variables which are numeric, normally these are numerical data that are normally distributed. What they have mentioned in the protocol, normally distributed numerical data with when there is a hypothesis of difference with more than two different groups, they usually do a t-test. So there are multiple outcomes where they have done t-test, and this multiple t-test, you cannot have a p-value in the secondary outcome to say whether that event is actually significant or not, because the total number of sample size is adequately powered for the primary outcome, not the secondary outcomes. Correct. So to get a p-value with where you have multiple t-tests done with multiple comparisons, they have done this Bonferroni correction to give a final p-value, as you have mentioned, they have mentioned is 0.003. Correct.
Yes.
So the individual outcomes in the secondary, if it was less than 0.003, then it was considered significant, but none of the outcomes were actually significant. So basically, it is tested, is done for post hoc analysis of any data. The Bonferroni correction is used. Rest all you have clearly explained, and it was a very nice presentation. I hope nobody has any queries, so we can wind up this session. Thank you all.
Thank you.